My talk is on resuscitation status and goals of care. And often when we talk about resuscitation, we ask patients we ask them about their code status, or that's the term that's used amongst the professional staff. And as you heard, code blue is when the patient has cardiac arrest and chest compressions and defibrillation is done. So the code status refers to the wishes of the patients or their substitute decision maker regarding their resuscitation wishes. So physicians seek to establish the goals of care through discussions with the patient or the patient's family if their patient is unable to have these discussions. Families are often present when these discussions are had with the patients. And a patient may decide for full aggressive measures, including CPR, defibrillation, and life support, so full code. Or alternatively, they may choose to be a DNR. So what is a DNR? A DNR just stands for do not resuscitate. So in accordance with the patient's wishes, should the patient's heart or lungs stop working, then CPR, defibrillation, a breathing tube, and life support will not be used. So a common concern is that if a patient decides that they are DNR, that they won't receive care. And so does a DNR mean no care? And the answer is definitely no, not at all. A patient who wishes to be DNR continues to receive full medical management, but in the event that their heart or lungs should stop, then they will not receive aggressive life-sustaining treatments to try and revive them. So they will not receive the chest compressions, they will not receive the shock, they will not be placed on life support. So you might be thinking in your head, if I am coming into the hospital and my heart has stopped or my lungs aren't working, how is it possible for someone to ask me whether or not I want to be a full code or whether or not I would like to be DNR? And this speaks to the importance of advanced directives. So every patient is assumed to want full resuscitation or to be a full code unless they previously stated otherwise. So every patient who comes to the hospital is treated as if they're a full code and everything is done to try and fully resuscitate them unless they previously expressed wishes. And if the patient is unable to make those decisions or to have that conversation, then the decision falls to their next of kin. So there's different types of advanced directives that one can have. A living will is the one that most people talk about and think about. A power of attorney for personal care, which you can have in conjunction with your living will. You can have previous DNR status on the hospital chart. You can have discussions with your loved ones, your next of kin. And really all of these, having the four of them together would be best, but you can have any assortment of these advanced directives. The first two take a little bit more planning. And the living will is actually a document in which you write down what you would like to happen if you become ill and can't communicate your wishes regarding treatments. It's common for people to write in their will that they do not want to be kept alive on artificial life supports if they have no hope of recovery. That's a very difficult statement to interpret because nothing in medicine is usually 100%, and everybody's definition of hope is slightly different. So some people might think that having a 1 in 10 chance of recovery isn't acceptable, or is acceptable, and someone who might think that if their chances are 1 in a million, then that's still a good enough hope for them to go along and continue with their resuscitation. So, it's important to have thought about it and to have documented your wishes, but it's also important to have had a discussion with your substitute decision maker. Substitute decision maker is a term that we use, and it's the person who makes the decisions for you if you're unable to. It's usually your next of kin. So if your next of kin, there's a legal form of who is the next of kin. If you're married, it's your spouse. If your spouse is unable to make those decisions, or if you're not married, then it falls to your children. If you don't have children, it becomes your parents, and then it would be your siblings, and in the absence of family members, it would be the public guardian. So if you choose not to, or if you would like someone besides who you're legal next of kin to make those decisions on your behalf, then you can draw up a power of attorney for personal care. And what that is it's a legal document that's drawn up, and it states who you would like to make these decisions about medical care on your behalf if you're not capable. It's not the same thing as a power of attorney for finances. It's a specific document that's about personal care. And it can be anyone who you choose, as long as they agree to be your power of attorney for personal care. You can have a Dnr chart, so patients who have been to the hospital previously or have had discussions with their physicians and have said that they do not want to be resuscitated, then there is a note placed on their chart that they do not want to be resuscitated in the event of their heart or lung stopping. So the most important of all of these things is to have discussion with your family members, your loved ones, your next of kin, because a living will can't anticipate every scenario. And as I said, everybody's idea of what they consider acceptable is a little different. So it's important for your substitute decision maker to understand your values and your choices and your wishes, because what you deem an acceptable quality of life may be very different from what they deem an acceptable quality of life. And so this person is going to make decisions on your behalf based on what you would like from them, like and what you decide is an acceptable quality of life. So it's very important to have these discussions. Have a living will is wonderful, and really to talk about it with your loved ones. And one last thing just to mention is that no decision is final. A patient can reverse their do not resuscitate status. If things have improved and they're getting better, or they've just changed their mind at any point, they can ask to be a full code. And conversely, a patient who was previously wanted to be a full code can change and become a do not resuscitate if that's what they would like. So no decisions are final.